Disorders of myocardial contractility. This is part 3. Of the lecture on cardiovascular alterations. Pericarditis is inflammation of the pericardial sac. It's a sac that's around, it's a two-layered sac around the heart muscle. The first layer, inner layer, is attached to the heart muscle, and the outer layer is the outer part. And in between, there's about 20 to 50 milliliters of lymphatic fluid normally that's circulated through the lymph system. When you have inflammation of that pericardial sac due to infection, connective tissue disease, radiation, or an autoimmune disorder, that fluid level can change, and the characteristics of it will change. And it can cause a severe chest pain that's worse with respiratory movement because the lungs rub on the pericardial sac. The friction rub is the classic sound. Again, it sounds like two pieces of leather rubbing together. It can cause severe problems when you swallow because then the esophagus rubs against that pericardial sac. It can cause a low-grade fever, generalized weakness, anxiety, ST segment elevation without the presence of a Q wave or T wave changes on your 12-lead ECG, and your cardiac enzymes will be normal. Complications of pericarditis are pericardial effusion. This is when you have fluid, excess fluid in the pericardial sac. The type of fluid there determines the type of disorder. If it is a transudate, it's serous, probably due to overhydration, left ventricular failure, or low protein levels in the blood. If it is an exudate, it's serosanguinous, which is blood, probably due to TB, tuberculosis, cancer, uremia, or radiation. If it's sanguinous, that's just pure blood. That's usually due to an aneurysm. The serosanguinous has plasma with it. So this could be, sanguinous could be due to an aneurysm leaking, trauma, or clotting problem. Or it could also be chyle, C-H-Y-L-E, which is cholesterol deposits. And that's when you have somebody who's severely hyperlipidemic. Cardiac tamponade is when there's so much fluid present within that cardiac sac that the heart is unable to fill adequately or contract appropriately. And if it is unrelieved, it will lead to death. And you can remove that excess fluid, the physician can with a needle, or if it's something that's going to reoccur, they will do what's called a cardiac pericardial window, and they'll cut a hole in the pericardial sac. Constrictive pericarditis is when the pericardial sac becomes a rigid shell, fibrotic in nature. This is due to a decrease in cardiac output, probably from TB, tuberculosis, radiation, uremia, rheumatoid arthritis, or coronary artery bypass graft surgery can also cause it. Cardiomyopathy is a disease of the myocardium due to infection, exposure to toxins, nutritional problems, or genetic changes. There are different types. Dilated or congestive is symptoms that mimic congestive heart failure. It involves both chambers of the muscle wall and is a problem. Hypertrophic used to be called IHSS, or idiopathic hypertrophic subaortic stenosis. Symptoms here mimic left ventricular failure, and the chamber size itself will decrease in size because it hypertrophies and cannot pump the blood out, so the opening gets more narrow. Restrictive is a genetic cause. This is when your myocardium stiffens. The eventual effect is heart failure, and the only cure is a heart transplant. And there's a table that discusses this on page 639 in your textbook. But this is another picture that shows the three different types. You can see hypertrophic cardiomyopathy on the far left and restrictive cardiomyopathy on the far right. And in the middle is congestive dilated, which is the most common cause, with their associated symptoms. As you can see, some of the symptoms are the same. Here's a picture that shows the normal heart on the left, shows the dilated congestive cardiomyopathy on the right, because it affects both. This one again is showing normal ventricle up above and shows the dilated cardiomyopathy down below. Normal heart left, hypertrophic heart on the right. And you can see there's not a lot of space there to pump anything out. Disorders of preload. These are disorders that affect valves. You're going to have valve dysfunction. Remember that normally your valves are watertight and normally they open without any sound being made. There is a table in your textbook on page 640. Stenosis means that you have a problem with that valve opening. Insufficiency means that you have a problem with the valve closing. And insufficiency has multiple terms. It could also be incompetence, regurgitation, or prolapse. All mean that the valve is not closing tightly. But eventually, this will cause an increased workload for the heart and hypertrophy of the heart muscle. Symptoms are a murmur and the effects of either increased or decreased blood flow. So if you look at this diagram, normally valves close watertight and open widely without any sound for the blood to go right through it. So if you have a stenosis, the stenotic valve is thick and bound down by scar tissue, so it only opens part way. Where insufficiency, regurg, incompetence, or prolapse, the valve opens perfectly fine, but it doesn't close properly because the valve leaflets are puckered and pulled apart by scar tissue, so it doesn't close right, and blood can back up behind it. Both of these result in a murmur. And heart murmurs depend upon, are defined by what they sound like. Do they occur in systole or diastole? Do they get louder in systole or diastole? Do they occur in the middle of the beginning or the end of either systole or diastole, or is it throughout the whole phase of systole or diastole? Keep in mind, up to about the age of 21, you can have a murmur that's totally normal because you're a child. Or if you're pregnant. Again, these will be systolic type murmurs that you'll notice. Those can be totally normal during those times. And this is from the memory book. And this is another way to remember murmurs, the location of them and what those valves are. We were taught ape to man, but this is talking about where they are in the valves. So we've got tricuspid, pulmonic, mitral, and it's tissue paper myacids. And the last is the aortic. So you know those valves. And this is where you listen to auscultate. Now, if you know what happens normally, you can identify by the sounds that you hear the problem the person is having. This is normally. Now, when I talk about systole, which is contraction of the ventricles, I'm referring only to the ventricles. We also have atrial systole, but atrial systole occurs during ventricular diastole, and the atria only have to pump as far as the ventricles. So it doesn't have a huge amount of impact on our cardiac output. It can affect our cardiac output by about 15 to 20% if it doesn't occur properly. But for the purposes of this lecture, when I refer to systole, and for the purposes of testing, when I refer to systole, I'm talking about ventricular systole, not atrial. So if you hear a murmur in systole, in the second intercostal space, right sternal border, you're talking about the aortic valve. And normally in systole, the aortic valve is open. So if you hear a murmur then, you have a problem with stenosis. If you hear a systolic murmur in the fourth ICS, left sternal border, ICS intercostal space, left sternal border, it's the tricuspid valve, which is normally closed in systole. So the problem is one of insufficiency. Now look at diastole. I'm referring to diastole, I'm only referring to ventricular diastole. Thus, if you hear a diastolic murmur in the second intercostal space left sternal border, The valve is the pulmonic valve, and it's normally closed during diastole, so then you have the problem with insufficiency. So if you just remember what normally happens, because normally the tricuspid valve and the mitral valve are open in diastole, and the aortic and pulmonic are closed. If they were not, blood would just kind of like flow right through the heart without any push to it, and it wouldn't circulate very far. Here's another diagram that talks about the different sites you need to listen to for the murmurs of the abnormal heart sounds. Remember, sound does not occur over the location of the valve, but radiates to those sites where they'll be heard best. And that a valve normally only makes a sound when it snaps closed, not when it opens. These again are showing different places you can listen to the heart to find the different sounds. Mitral valve prolapse is a type of mitral insufficiency. It's the most common valve disorder in the United States, occurring in young women, more so in young women. In fact, it's so frequent, like about 80% of all young women have some type of mitral valve prolapse. Some physicians are considering it a normal variant and are not treating it at all. It is due to an autosomal dominant gene. It is associated with connective tissue disorders such as and hyperthyroidism. But as I said, it's possibly a normal variant. So they used to medicate patients before they had any sort of dental work, and now they're not necessarily doing that any longer. If the patient has symptoms, on the other hand, they will treat those symptoms. Palpitations are due to the tachycardia and the dysrhythmia, and oftentimes they're placed on beta blockers for that. An increased cardiac workload occurs, and that can cause, decrease in cardiac output will cause lightheadedness, syncope, shortness of breath, fatigue, lethargy, and weakness. That increase in workload for the heart muscle will cause atypical chest pain and chest tightness. Again, the beta blockers tend to work fairly well for that. Anxiety, depression, and panic attacks can also occur, and that anxiety will increase the respiratory rate. And again, beta blockers work fairly well for that. And this is showing your mitral valve on the left because it ends in L, and this is showing what it looks like on the far right, what it looks like when it's prolapsed. Aortic stenosis in a child will cause left ventricular hypertrophy, decreased coronary perfusion, and a subendocardial ischemia. In this condition, the aortic valve between the left ventricle and the aorta did not form properly and is narrowed, making it difficult for the heart to pump blood to the body. A normal valve has 3 leaflets or cusps, but a stenotic valve may have only 1 cusp or 2 cusps. Although aortic stenosis may not cause symptoms, it may worsen over time, and surgery may be needed to correct the blockage, or the valve may need to be replaced with an artificial one. Symptoms are hypotension, tachycardia, poor feeding, a loud, harsh systolic murmur, exercise intolerance, and chest pain. Pulmonic stenosis in children will cause right ventricular hypertrophy. Pulmonic atresia is the extreme form. It's a complicated congenital defect in which there is abnormal development of the pulmonary valve. Normally the pulmonary valve is found between the right ventricle and the pulmonary artery. It has 3 leaflets that function like a one-way door, allowing blood to flow forward into the pulmonary artery, not backward into the right ventricle. With pulmonary atresia, problems with the valve development prevent the leaflets from opening. Therefore, blood cannot flow forward from the right ventricle to the lungs, and it will result in no flow to the lungs. The symptoms are cyanotic atrial septal defect, right to left shunt, and a harsh systolic murmur. If they didn't have that ASD, they would have no blood flow and they would not survive. And this is where I will stop part 3.